Welcome, everyone, to the second webinar of this three-part Inherited Arrhythmias webinar series. As Sammy mentioned, my name is Layla Shamrazadi. I'm a genetic counselor here at Ambry Genetics. And today, on behalf of Ambry and the SOUDS Foundation, I'm honored to introduce a wonderful group of speakers. The title of today's presentation is Family Experience with Sudden Death. And during this presentation, we have three speakers who will provide a perspective of sudden death, beginning with the cardiovascular and genetic evaluation, and then we will discuss the family journey of sudden death through the perspective of a mother as well as a nurse practitioner. At the end, as Sammy mentioned, we may have some time for Q&A, so please feel free to submit those questions in your Q&A box on your screen. With that, I'm very excited to introduce our speakers. Our first speaker is Julianne Wojak. She's a licensed genetic counselor at the Heart and Vascular Center at the UCSF Medical Center, where she coordinates the cardiovascular genetics program and provides genetic counseling services for patients with hereditary heart conditions. Here she assesses the patient's medical and family history to determine the genetic nature of heart disease in the family, discusses the benefits and limitations of genetic testing and cardiovascular screening, and helps families understand and cope with the emotional and familial implications of inherited heart conditions. She has also co-created KinList. This is an online resource and medical assessment tool for family members of sudden cardiac death victims. Our second speaker will be Mary Hardies. Mary is a registered nurse for the Community Mental Health Institution. She and her husband had 4 children, 2 boys and 2 girls, and in September 2002, they lost their 13-year-old son in what was initially deemed an accidental hunting accident. And on December 25, 2007, their 21-year-old daughter had a torsades event that eventually resulted in her death. These events began with a family journey with long QT and genetic testing. Ms. Hardies is a registered nurse, but will share her experiences today as a mother. Our final speaker is Ms. Bryn Deckert-Crook. Ms. Deckert is a pediatric nurse practitioner at the University of Michigan Congenital Heart Center, where she specializes in electrophysiology and cares for patients with sudden death conditions, children and adolescents with arrhythmias, and those with pacemakers and ICDs. In addition to her clinical role, Ms. Deckert has multiple research interests in pediatric patients with arrhythmias and sudden death conditions. She received her master's in science of nursing at Loyola University Chicago in 2004 and has worked with pediatric arrhythmia patients since that time. Ms. Deckert is a board member of the SOUDS Foundation and the SOUDS Foundation Medical Education Community member. We're very lucky to have all 3 of these speakers here today, and with that, I'll turn the slides over to Julianne Wojak as our first speaker. Thank you.
Thanks, Layla, and thank you to SOUDS and Ambry for sponsoring today's webinar and inviting me to share with you all. I'm grateful to have the opportunity to present with Bryn and Mary and on behalf of many of the families that I've been honored to work with. There we go. So for my portion of the talk today, what I'm hoping to do is kind of illustrate a practical approach to postmortem cardiovascular genetic evaluation for sudden death cases through some experience that I've had. There aren't great guidelines or best practices in the literature for evaluating families, and so I think it's a little bit of a case-by-case basis, and each case presents unique learning opportunities and unique challenges. I'll talk a little bit about some of these challenges and limitations, some of the barriers, and some creative ways to overcome them. Share some insight and perspective on behalf of family members that I've worked with. We could talk endlessly on the family perspective, so I will leave a lot of that for Mary to illustrate for us directly. I hope that this webinar serves as an invitation to collaborative learning and a call to action to create guidelines or best practices for postmortem cardiovascular genetic evaluation, because they're kind of desperately needed in this space. Referrals generally come from families themselves, either at recommendations from a physician or cardiologist, electrophysiologist. Sometimes they come from our colleagues in the community with SADS organizations or other advocacy or state or local organizations, and sometimes from medical examiners or cardiac pathologists. Depending on the setting and the relationship between local medical examiners and pathologists, you may or may not get more referrals that way. We have actually a wonderful, robust relationship with these folks here, so I get a lot of referrals from them. I think to start, it's important to get a good understanding of what are the objectives for postmortem evaluation, both from the family standpoint as well as systemically. Families generally have a number of questions. These are some of the common ones. They desperately want an explanation. They also want to ensure that everything that could have been done was actually done. I think this is a primary motivation for the evaluation, and sometimes just going through the evaluation, even if there's nothing definitive and clear was found, just knowing that absolutely everything that could have been done was done for their loved one is particularly therapeutic. Family members want to know if the death could have been prevented. Working with families in sudden death has been quite a learning curve for me personally, and initially I kind of thought that this would be a little bit of a taboo topic that people wouldn't want to talk about, and I've been surprised that it's actually quite the opposite. Families are already thinking about this, as painful as it is. They want to know if there was something that was missed, and also because that directly affects potentially other family members, is there something that they could be on the lookout for? Family members want to know, was this genetic? And in the typical simplistic terms that we often our families think about the term genetic, and when it comes to cardiovascular genetics, everyone who sees patients in this space understands that it's far from simple, it's far from straightforward, and when it comes to postmortem genetic evaluation, at least in my experience, it's as complex and muddy as it gets. So I think it's really important to get a sense of what the family expects, the information, the evaluation, any genetic testing will provide, and then to set very, very clear expectations around what it may or may not provide. The system has a whole different set of objectives that in some cases are aligned with the families, in some cases are not. While they're there to establish a cause of death, they're there to mainly a cause of death that's much more generic than what the family is desiring. The family wants to know the details of why did this happen, how could this happen, when the system is really designed to say, was this natural, was it not, identify any legal violations. And then they're also under enormous pressure from all the different variables that I've listed on this slide. And I have to have a lot of sensitivity and empathy for the medical examiner staff as well, because this is not their typical population, and they don't have the proper training, they don't have the proper facilities. Often they are ill-equipped to be able to help families through this process, in this devastating process. What I've often hear is families telling me how terrible the medical examiner or coroner's office is, and then when I reach out to talk with them, they're actually been quite, most of the time, not always, but quite eager to help from the back side. So, I'm just very sensitive to all of the inherent flaws in the system, and I think these folks are kind of doing the best that they can, given all of those barriers. Next, questions to answer are around the circumstances of the death. Some basic questions of was this sudden, was this cardiac, as simple as those seem, in practicality, they're not always so easy to answer. They're not always so straightforward. So getting to the bottom of what actually happened, was it likely to be a sudden cardiac death? Was it not a sudden cardiac death, but actually also significant for possibly an inherited cardiac condition, things like drownings or accidents that are suspicious, potentially medication, adverse effects from medications that could induce an arrhythmia. All these different things could be important in a cardiac setting. Whether or not the death was witnessed is particularly important. The investigation reports have some information from interview of witnesses when the deaths are witnessed, or interviews from family members who last saw the decedent. And there is some information that's valuable there, but I think it's very limited, and it may or may not be all that accurate. So I caution individuals who are looking at that information and really it has helped me a lot to interview families and try to get their report of it. The other thing that comes into play along those lines is the question of whether the witness accounts are actually reliable. And for a whole host of reasons, it's very difficult to accurately report history. And even when one witnessed it firsthand, when it's a sudden death, the trauma and the shock of being part of that experience is enormous, and that often colors the memories. The other thing that I found that colors the memories, which was interesting to me, is families have certain things they want to believe sometimes about the sudden death of their loved one, and particularly wanting to believe that they didn't suffer. And so sometimes the accounts that I've found have been in some ways colored a little bit by this desire, understandably so. So it takes a little bit of investigation and curiosity around what really is going on around the circumstances of death, and there are lots of limitations. The decedent's past medical history is particularly important, and there's lots of limitations in this space as well, depending on who and how old the individual was. If it's a pediatric case, generally parents have this information readily available or at least accessible. If it's an adult who lives independently, maybe not. If it's a spouse, then somewhere in the middle potentially. If there is any reported past medical history, it's absolutely essential to verify it with medical records. As we all know, generally taking medical history, cardiac medical history, is ripe with inaccuracies, and that happens with regard to this as well. Finding out if any cardiac testing was done prior to the sudden death is imperative. Even if this was supposedly normal, still get the records, and I would say get the primary records rather than just reports or interpretations by cardiologists or even primary care doctors. I always request all of the echo images or MRI images if they were done, and any of the EP data, because having our providers scrutinize it is a different level than potentially someone who wasn't trained. Finding out any medication use. This is important to get a glimpse into past medical history if it's otherwise unavailable. Medication use is also important if there were any medications that could potentially increase risk for arrhythmias in the setting of a genetic arrhythmia condition like long QT or Brugada. Symptoms, this was another area where I kind of anticipated family members having a really difficult time considering the possibility that there could have been symptoms prior to the death, but in fact, I've generally found that they're scrutinizing the history themselves, so very eager to share what they learn. So we talk a little bit about what symptoms were there. Were there any atypical symptoms? Were they unrecognized? And keeping in mind that all of this is subjective. So whatever is reported, you take a little bit with a grain of salt unless there's some degree of data to support it. Another potentially painful thing to discuss is lifestyle. The idea that the loved one's own lifestyle in any way caused their sudden death or played a role in their sudden death, better said, is really painful for family members. So having a ton of sensitivity around all of this line of inquiry is absolutely imperative. The reports from the postmortem evaluation are extremely valuable. An investigation report, like I said, has some of the information that we will need around the circumstances of the sudden death. Keeping in mind that this has incredible emotional implications for the family members, and these can be very difficult for family members to read or have access to or whatever. So it's just being very sensitive. Also keeping in mind that the investigation reports they may not be all that accurate. I've had situations where what's in the investigation report may be details that are, may or may not be imperative to your evaluation, but the inaccuracies actually affect the degree of faith that the family has in the entire investigation process, which is kind of understandable and interesting. Autopsy data is great if you have it, if one was done. Sadly, as we all know, autopsies are not commonly done in sudden cardiac death. Even if done, keep in mind that this is one provider's opinion on what they think the sudden cardiac death was due to based on their findings, and there's no ability to get a second opinion because nothing is saved. So although autopsy data is fantastic, I would say the lesson I've learned over the years is trust nothing and get lots of second opinions. So I, will have autopsies reviewed by medical examiner colleagues or cardiac pathology colleagues, even just to get a sense of whether they think it was an effective autopsy or if there are findings that are somewhat unexplainable. I like to review these with experts just to make sure that I'm starting in the right place with regard to interpretation. Autopsies can be incomplete as well, and I'll touch on that a little bit further on. Toxicology is key, just making sure there's no other possible explanation for the sudden death. I am a big champion of having slides reviewed, cardiac slides reviewed in the case of autopsy-negative sudden death or in the case of potential cardiomyopathy. Really important, and I've found invaluable. Diagnoses like ARVC are miscalled far more frequently than they're accurately called at least in my limited experience. I've even had clear-cut cases of what seemingly are clear-cut cases of hypertrophic cardiomyopathy on growth that actually looked really different on microscopic, and likewise of autopsy-negative sudden death from a cardiac standpoint on growth and actually having microscopic evidence of cardiomyopathy. So, I learned so much, and I happen to have access to a wonderful cardiac pathologist, so I'm blessed in that regard. But if you have it, definitely take advantage of that resource. And then within the postmortem evaluation, we need to get a specimen inventory. We need to get an idea of what was saved, what are the conditions in which it was saved, how do we transfer that specimen out if we want to use it, et cetera, et cetera. The autopsy data, or sometimes the report has some of this information. Most often it doesn't, and it's not complete. So it's a lot of phone calls and emails back and forth to make sure that you have an exhaustive list of everything that was kept and then how it was actually stored. The family evaluation happens at the same time, and so family members are evaluated to see if they have any evidence of a genetic arrhythmia, including taking a detailed family history that needs to be verified with medical records. The timeline around family screening is really important to touch on. In the setting of sudden cardiac death, these need to happen immediately or as soon as possible. In the setting where relatives are actually symptomatic, it needs to be absolutely urgent. If they're young or have lifestyle factors that suggest that they could be at imminent risk for arrhythmias, then these evaluations need to happen ASAP. From a psychological standpoint, especially if the sudden death was in a young person, I think that psychologically we need to get these families in immediately so that they can be checked and reassured. I'll point you to the HRS guidelines for a basic cardiac workup that's recommended in the setting of sudden cardiac death. But generally speaking, EKG, echo, potentially stress test, potentially MRI, to look for all of the major players. There are tons of obstacles to family evaluation, and we could spend a whole talk discussing that, and it would be really interesting to get family perspective on what the obstacles are. I think the biggest obstacle is lack of awareness, both on the professional as well as the patient level. If people don't know there could be a risk to family members, it doesn't even matter what all the other obstacles might be. So starting with increase in awareness around this is imperative. Genetic evaluation is kind of your typical stuff at the beginning that listed on the slide. The first step that I like to take a lot of time with is really understanding what the family's motivation is. It might be not what I would anticipate they want. They may not want genetic testing. They may not want the extensive family involvement. They may just really want to make sure that we can get specimens transferred for DNA banking, for example. So understanding what that is, where they're coming from, and then also being able to use that to move forward to say, well, these are the other issues that come up, and certainly supporting family on what their desires are and educating them on what else they may be missing. It's important to figure out who in the family has the emotional bandwidth to be able to kind of help with this process. Obviously, talking about sudden death, all the circumstances around it, all of the history of their loved one, family history, and then the autopsy details and specimen details, it's extremely triggering and painful. So finding a family member that is capable of having that conversation, and then identifying communication preferences. And so I spend a lot of time just at the beginning contracting with families and saying, how do you guys want to handle this, and what part do you want me to do? Who do you want me to contact? When do you want me to contact? Generally speaking, I offer to do pretty much everything and have patients sign kind of consents for pretty much everything I need, and then they let me just kind of run with it, and everybody so far has really appreciated that. I keep people updated along the way at major developments, but certainly not all the nitty-gritty stuff. I just kind of take a big picture approach with them, and that's been helpful. It's extraordinarily time-consuming and requires intense organization and persistence, but I think it's very helpful for the families. A family history, risk assessment, differential diagnosis, that's all typical what you would do in general genetic counseling. The genetic testing is a bit unique. Obviously, we need to make sure that there's an adequate specimen. Check out the NSGC website, Postmortem website, for the ideal guidelines for postmortem genetic testing. I would say, obviously, if you can get frozen blood or fresh blood or fresh tissue, that's great. But don't write it off just because you don't have those available to you. I've had lots of success with different types of specimens. There's, things like DNA cards that the medical examiner's office may have. Some states actually even have newborn screening DNA cards that you may be able to get access to. My approach is, let's find out absolutely everything that's available, and let's see where we can get DNA. I've even had some luck with getting DNA out of other labs that the decedent previously had genetic testing, and I just actually convinced 23andMe to release one. So it was apparently their first time, and I know they've tested tons of people in the world, so maybe that's an option too. Very, very careful genetic counseling around all the things that come up with genetic testing, and cardiac genetics is mandatory and much more comprehensive and slow and methodical when it comes to postmortem cases. Genetic test results. So we all know why we do genetic testing in this space. We want to figure out what caused somebody who is presumably healthy to die suddenly, and find a clear genetic mutation and test family members to see who in the family is at risk and who isn't, and that allows us to provide adequate care for those who inherited the mutation and reassure those who didn't. So that's all wonderful and noble and very powerful work, and that's what we're all here trying to do. In practice, I think it's far from that in ideal in practice. Most of the time, I would say the postmortem genetic testing I've done presents more questions than answers. Variant interpretation is even more challenging in this setting. We find unexpected or inconsistent results all the time. We might find what appear to be disease-causing mutations in genes that are not consistent with the phenotype. We find tons of uncertain variants that, we have no idea what to do with from a family setting. Many of these families don't have a clear family history, so there's no ability to do co-segregation testing. So there are lots and lots of limitations in at least my particular clinical experience. Depending on the extent of genetic testing that was ordered, that also will influence this. And it's a moving target for me as far as I kind of waffle between real targeted cardiac panels and then real expansive cardiac panels. And I have a detailed conversation with families about it because I don't know what the right answer is. I certainly always recommend and facilitate anything that has a high degree of clinical suspicion according to the differential. But when it comes to casting a really broad net just because we can versus starting more focused, I take the direction of the family because dealing with these uncertain variants is really tough in at-risk family members, particularly pediatrics. And then I have another moving target with kind of where I'm at with theoretically using this information is how certain do we need to be about a genetic variant, the pathogenicity of a genetic variant to use it for family assessment. I think the dogma in genetics has always been if we're not 100% sure, then we don't test anyone who's unaffected. And so it's a moving target. There's especially as the amount of genetic data that we're able to get in genetic testing has increased dramatically. I think that there are these variants that are really plausible variants where we think it's probably disease-causing. It's just rare. And in those settings, that actually may be very useful to use for family members with very cautious interpretation. I'm very reluctant to suggest that anybody should be released from screening, and certainly not if there's any degree of uncertainty. But I think that there's some nuanced benefit to using at least some of these variants that we're pretty suspicious of in family assessment. But again, it's an area that I would love to get others' opinions on because it's not easy stuff. I'm not too clear on too much other than the fact that I think that there's an enormous role for DNA banking here. So please bank DNA whenever you have a choice. It is incredibly important for the obvious medical reasons, but also for the emotional reasons. I have had families that, just the idea that they've done everything they can do, that some of their loved ones' biological material is available for future use is incredibly therapeutic for them. There's not downsides. If you have DNA, there's no downsides to DNA banking. It's inexpensive. Again, it's easy. There are lots of labs. So I'm a big champion for DNA banking, especially in this setting. We could have a whole lecture, a whole afternoon on the psychosocial of a sudden cardiac death. Suffice it to say, here are some kind of points that come out. It's a lot of the traditional psychological, psychosocial, family dynamic reactions that come up in hereditary cardiovascular disease, period. But they're all highly charged and highly intense. And these are just extraordinarily painful situations for families who are actively grieving. Typically, families kind of, in my experience, they get enough strength to kind of go forward, and then they kind of back off as it kind of parallels the cycle of grief symptoms. So you have to have a ton of patience and empathy for what the families are going through. There's going to be times when they just don't have the capacity to be able to move forward, and they need a little break. They also have logistically competing priorities. There's a whole lot of things change when your loved ones died suddenly that you need to attend to and you need to figure out. Many people, especially if it's an adult, a spouse, there's many life lifestyle adjustments, just practical things like living, home, insurance, et cetera, that is all changing. The family dynamics are extremely charged, and it's depending on who the next of kin is that has legal authority over the use of these specimens, it brings up a whole host of issues that, and a whole host of family dynamics and potential conflict that, is really intense for the individuals that you're working with. So I'm just humbled every time I'm working with a family in this setting of how they're able to kind of navigate these just enormously turbulent waters just within their own pain. I'm looking at the time, and I am happy that I'll be ending here to give time for Bryn and Mary. So just to summarize my little piece of the overview here is this is a complex process and extremely time-consuming with lots of barriers. I haven't even touched on the financial barriers that come with who's paying for this and how it's reimbursed, et cetera, but there are barriers there as well. Given all that, there's incredible potential to help families, and so I think it's absolutely important that we're all doing this work. It does require creativity, organization, a ton of persistence, and a ton of patience. Please bank DNA, and let's all work together to be able to learn from each other and develop some guidelines so that we can better serve these lovely patients and families. And I'm done, so we'll turn it over to Bryn and Mary, right?
Yes, this is Mary Hardies. And I am talking as a mother of two children that had died suddenly. My son, in September of 2002, died from what we thought was an accidental hunting accident at the time. However, when they did ballistics, they said it was odd that he was obviously already leaning over the platform when the gun had discharged, and he was shot. They never could explain that. They couldn't explain really why my daughter, who was with him at the time, said he never made a sound. She never heard him holler, yell, or anything. And he was almost 13, 10 days shy of being 13 when he died. He had reactive airway issues, and he was on inhaler Ventolin at the time. He played youth football. It was very hot that fall. He had played 4 quarters the night before his death and had used his inhaler at least 3 times that night and once the morning of the incident. And that took us 5 years later to my daughter, Heidi. She was 5 weeks after having delivered her first child, and we received a call that morning from my son-in-law that he had called the first responders because he had heard a thud after the phone had rang, and she had been nursing the baby, and he heard the baby cry and heard a sound, went to investigate and said her respirations were very abnormal, so he started CPR. The EMS was there rather quickly, but they were not able to get a sustainable heart rate for almost 35 minutes. So by the time we had her at the local hospital, they were pretty certain she had probably a significant amount of brain damage from the anoxia. The consulting cardiologist at the time did say that he felt that the event that triggered it was an arrhythmia, but they didn't know of what type. Didn't have a lot of information for us at that point. And by the time mid-morning had rolled around, they were more worried about the brain injury because she was having seizures at that point and a lot of tremors, and we knew that she had suffered a significant brain injury. But the second night at that hospital, she did have a torsades event, and they did identify it, and we were transferred to a larger medical facility at that point where the cardiologist there said, yes, she had a long QT, and kind of gave us that diagnosis, but we didn't have a lot of information to go from, and like Julianne was talking about, there are so many things going through your mind at that point that it was very hard to process process it all. So it was just a piece of paper that I put on the desk, and I waited with it until we could deal with it better. But a couple weeks later, one of the nurses up in the intensive care unit, while she was being transferred to a hospice unit at that point, made it perfectly clear to me, got a hold of me and said, you have to test your family. You have to do it right away. You have to test Heidi so you know what this is. And then I kind of started to understand how serious it could be and what ramifications it could be for other family members that were still alive. And so at that point, I got a hold of SADS. They were able to give me the information I needed on how to get the genetic testing in a quick way. I think by the next day I already had the name and the number and was in the process of getting it done. By the time we tested her, she only lived maybe 4 days after the date of the testing. So that was wonderful for us because we actually got a diagnosis of long QT2, so it was definable. And at that point, another medical professional had told us that that could have been very well what had triggered Ethan's event 5 years earlier, because he was the right age for a boy. He definitely had been taking meds he shouldn't have done, was doing activities that he shouldn't have been doing, had we known differently. So at that point, when they said do genetic testing as a family, I was thrilled because all I could think of is now we will know for sure we'll have something to hold on to. It's not just, you're having children randomly drop dead. And our children, my remaining son and daughter, tested, and they were positive. My grandson, Heidi's son, was positive. Myself, I am positive. I have 5 siblings, and all of my siblings tested except one brother, and they were all negative. Out of 6 children in my family, the only one that is known to be positive is myself, and then the one unknown, my brother. And why my brother didn't test, I think he was worried about ramifications with maybe getting insurances and jobs and things like that, so he's always been hesitant to do that. Although he does follow, there are lists for drugs not to be on when you have long QT, and he does keep up with those lists, and he asks that the doctors abide by those when they're treating his children as well. And that brings us up to we've all been tested. We are all on beta blockers. The lifestyle changes, initially I thought, well, no startles and things like that for long QT. Those were kind of minor things. But there were some interesting things when you come to insurances because with the Nadolol especially, there was a couple years there where Nadolol became very expensive. And if you didn't have good script coverage, it was very difficult to get, and you had to kind of loop through special programs to get it in a reasonable range. And so we have had some issues like that. There's always the challenges with healthcare providers that are knowledgeable of the condition, and even when you present it, sometimes they don't want to read the list about what meds not to use. As a family, we have used, before we go on anything, we talk to each other, we look at the QT list ourselves, and I go to our electrophysiologist a lot and just put a call through to him and say, they are recommending this, what would you recommend? And he has been excellent about getting back with us on a timely fashion on what is acceptable and what is not. You definitely learn to be your own advocate. And you always learn that there's something new. Every year it seems to be something new comes up, like when my children started to date, all of a sudden they were confronted with, wow, how do I tell somebody that I might be thinking of being serious with that I have this condition and it can affect our children? A lot of situations like that have worked out, but is very testing for the kids especially. And then with other family members, everybody has an opinion what you should do and what you shouldn't do. And even when they do decide different avenues, my son just had their first child here in February, and we had talked to the electrophysiologist, and he said, oh, you know, you can just get testing from the cord blood of the baby, and it'll be fine. But what we didn't realize was when we took it to the OBGYN, you know, it automatically puts you at a high-risk pregnancy, and it was quite a complication, actually. We live in a rural area, so they had to drive 4 or 5 hours to deliver this baby in a bigger medical system. And so there's a lot of things that come up that you just never know until it comes up in your life. The maternity care that we had for my granddaughter was great, and initially she was in another study through the SADS. She had an EMG that was done in Wisconsin, which is the EEG that they do while the baby is still in utero, and it was questionable, and so they deemed her as positive until after she was born, and then the cord blood testing came out negative. But that, again, is a whole, you know, puts a whole other level to prenatal care.
Great. Thank you, Mary, so much. This is, my name is Bryn Deckert, and I'm a nurse practitioner at the University of Michigan, and I have the pleasure of actually caring for Mary's family here with the team at the University of Michigan. Just to start off with, this is actually Mary's family history that was put together by one of the genetic counselors that I work with here. Mary did a great job explaining who's been affected by by long QT. I think that her son is still questionable, even though he never had a test. It does sound that sounds like there's a distinct possibility that his hunting accident may have been due to a startle or something associated with hunting. I just want to go on to talk about some of the other things that are keys for clinicians who are caring for patients with sudden death conditions. Like I said, I'm lucky enough to be able to care for Mary and her family, and I think one of the keys is actually obtaining a thorough family history and investigate all of the information. So as Mary said, her son had died several years before, and I think that, you know, everyone just kind of chalked this up to a hunting accident, but I think gaining that information would have been very helpful at the time. But I think also at the time, you know, this disease probably wasn't in the mainstream as it is now. As we know, structural heart disease can be found on the postmortem exam, but arrhythmic causes cannot. And so even if you have a postmortem exam, you may miss something like CPVT or long QT. As Julianne and Mary have both described, there should be clinical screening of first-degree relatives, and obviously that was done with Mary and her family and done very quickly. And as she said, it was lucky that her daughter was alive and blood was able to be obtained from her to have this testing done. Obviously, genetic testing is something that's very important, but I think a clinical screen can also just be an EKG, and then you can consider genetic testing as needed. I think Julianne described some of the issues with genetic testing. Everyone, especially if there's some sort of variant that's unknown, or how it will affect families. And the biggest thing, I think, is a multidisciplinary approach, and that includes support. I think that's something that we can do as clinicians, is to make sure that our patients are supported, is make sure that we have everyone who needs to be involved at the beginning. So there's a couple of research studies I'm going to go through. This one comes from Pediatric Cardiology and was published in 2016. And this was a study that was exploring the discussion of risk of sudden death. They interviewed 114 parents who had a child with SADS conditions. And a bulk of them answered this question: what is the biggest concern for your child? And the list was pretty long, but they were able to settle it down to a couple concerns that families had. They worried about disease progression, and they worried about the risk of sudden death. So obviously this is a big concern. If you have the condition or you have the gene, what is your risk of sudden death? They also worried about their children's quality of life. Obviously, there can be some lifestyle changes. What do they need to worry about? Can they go to school? Can they go to gym class? All of those worries really do come out very much in the beginning. And they also worry about when their kids become teenagers and the concerns for risk of noncompliance. When they're younger, you can make sure that they're getting their medications, but as they're getting older into their teen years and even into their early adulthood, they may choose not to be compliant, and that was a family's concern, was worrying about their kids as they grow.
A second question they asked was what resources were most helpful. I think this is important for us to listen to as healthcare providers, as we do provide very good information to our patients. They felt that we were very helpful. Other resources they felt were most helpful were websites that were out there, and then other affected people. There are programs across the United States, and I think SADS does a wonderful job with this as well, is basically connecting patients with the similar types of diseases with each other, and they can help support each other. So I think we do need to help patients come together with others who may have similar concerns that they have. Another study that was published in Perspective of Medicine in 2014 interviewed 50 participants from 32 families with cardiogenetic diseases. And they found three themes that emerged. First, a family bereaves, or they have bereavement. They feel numb. They don't know what to do. They need to know what happened, and they feel like it haunts them forever. I think Mary kind of alluded to that when she first found out about the diagnosis of her daughter, that it does take some time to get over. I think also many of these parents will have reactive anxiety about transmission. Again, they feel guilt. If they have the disease, are they passing it, or have they passed it along to their children? They sometimes feel like they're the only one that is affected. It's always on their mind, and they feel worried about or anxiety about sharing this information with their children. How much do they share? When do they share? And I think as healthcare providers, we can actually help them talk about these issues, especially when we see them in our clinic. Like Mary, there are many patients out there who have positive outcomes and who are resilient. Mary's a wonderful advocate for her family. She's also a wonderful nurse, and I think she has turned this disease into something that's positive. I believe Mary feels some closure and that every day is a gift, and that she is out there today, like we're talking about right now, creating awareness and sharing her story. So I applaud Mary for taking this horrible situation and making it a positive outcome for the rest of us who are listening today. I got a lot of this information actually from the UK. Dominic Abrams, who's one of the electrophysiologists at Boston, started a program there, and he actually sent this information to me that was published by the UK government about what a family needs when there's a sudden death condition. First, there's a timely referral to services. So families want to feel that they are are referred right away to the center that needs to see them. They also want recognition that the whole family needs care. As Mary has alluded to, we need to see the siblings, we need to see the grandchildren, all of the family members need to be continued to be followed. They also felt that one-stop shop for the diagnosis and management of sudden conditions is important. So we need to make sure we have effective communication and coordination. So even if you can't be a one-stop shop just because of your location, Mary lives in a small town, so she may not be able to have everything done there. If you do come farther away, we need to make sure here at the University of Michigan that we are communicating with her local physicians there, and so we're on the same page. And obviously, families want increased capacity of a multidisciplinary program to ensure that care is received by all those who require it. So again, we want to make sure that we're caring for the whole family and not just the one patient that might be affected. So we're going to go through these individually. So timely referral, obviously, Julianne went through some of this as well. There's guidelines and red flags from medical examiners. They need to know when to refer, what tests to run, what blood to save, when to DNA bank, all those things. They also need to know when to refer and where to refer. I think SADS does a great job with helping where to refer. They get patients to centers that can help care for their patients. And families also want a minimal wait time for their appointment. After a horrible tragedy such as Mary described, they want to get the family in right away to help relieve some of the anxiety if possible. Next, we want to care for the whole family. So we need to identify family members at risk. Again, we've talked about cascade screening. We need to have genetic counseling for all first-degree relatives. Julianne also talked about that. Mary alluded to the reproductive counseling is needed when her older children have become involved with partners down the road. They need to talk about this, what are the risks and all that before going ahead and deciding to have children. We also need to provide psychosocial support of the whole family, and we as healthcare providers need to be the liaison between specialists. So we need to make sure that we are getting people the care that they need, but also making sure that communication is happening if patients need to have medications for other concerns or they need to have surgeries. We need to make sure that we are the liaison for the family. So what is the family perspective? Again, this comes from the UK document. A parent actually said, which I thought this is a great perspective to have, that the person at the start of the chain, whether it's the general practitioner or in the event of death, the coroner, or the initial person dealing with the patient in the hospital, needs to recognize the possibility of familial consequences. Otherwise, the chain breaks at the first link. And so I think we need to recognize that the first person involved with this family needs to make sure that the family is getting where they need to go and take care of the whole family. So one-stop shop, again, I'm not sure that this is possible everywhere, but I think that many programs across the country can provide this, which is an integrated multidisciplinary approach. And if you can't do it in one building, again, I think effective communication and coordination is necessary. We need to collaborate with other specialties as needed. We need to provide continuity and also provide a holistic approach. So we really do need to follow the family and make sure we're caring for all of them. If we can focus the needs of the family in one place, that's great. Again, if you can't, at least have some sort of coordination with medical records or something so everyone's on the same page. Mary talked about worrying about healthcare providers' knowledge. So if she goes somewhere in her local community, would they know what drugs to put them on? And she feels like she needs to be an advocate for herself. And so we need to help also be an advocate for these families. And again, the one-stop shop can be convenient for families if it's possible. I think there are a lot of players that go along with caring for patients with sudden death. So obviously the family is in the center, but there are many other healthcare providers or community providers that we need to work with. Obviously, some of these kids are going to school, and many times, Mary, I'm not sure if you've had this issue, the school is very nervous about having someone with this type of disease in their school and what to do in an emergency. So I think as healthcare providers, we should be talking with communities, making sure we're either visiting the schools or talking to them on a regular basis to make sure that they understand what to do in an emergency. Obviously, we can't predict every event, but I think we can alleviate some anxiety and alleviate some fear just by talking through with them what would they do if something were to happen at school. Obviously, the primary care provider is a big key in this relationship. We need to continue educating primary care providers about drugs to avoid, and again, keeping communication very much open. Obviously, the PCP is the first person that these patients see in many instances, and just keeping that relationship effective. The adult team and the pediatric team, obviously families can have adult members with the disease as well as children with the disease. So if patients are seeing, families are seeing two different specialists, making sure that communication is perfect and making sure that we are continually talking with each other to make sure that, we are communicating and taking care of the family. Some families require psychology or some sort of social work, and I think psychology can either be a counselor, it can be a psychiatrist or something to just support the family and their psychological needs. Obviously, genetics and pathology is a big contributor. They're able to do the genetic testing. They're able to do the counseling. And we are lucky enough at the University of Michigan to have a genetic counselor on staff in our arrhythmia clinic who can provide the service, when patients come to our clinics, they're not needing to come back. Social work can actually be helpful in helping with insurance needs and also providing patients the support they may need. So education, obviously the healthcare providers need to provide education and let families know where to go on their own. The SADS website has a lot of information. If you call SADS also, you can get providers in your area if a family needs that. Hypertrophic cardiomyopathy can be, another, condition that you can have, and you can go to their website for similar types of referral. Heart Rhythm Society, as well as the PACES, which is Pediatric and Congenital Electrophysiology Society, does have some information. You can also look up providers on both of those sites. Other things that we need to worry about are drugs to avoid. So obviously Brugada drugs for Brugada syndrome and long QT drugs are found at crediblemed.org. And so I think this is an important thing to remember and also talk to our families about. So some of the education that we need to provide is sports. So can they play sports? Obviously, the new guidelines are out now, are a little bit more liberal, but that's something you need to talk with your families about early on. Swimming risks. So obviously, swimming in murky water can cause issues, especially for long QT patients. So we need to make sure we're discussing that. We need to talk about AEDs. So some families may require AEDs or may be recommended that they have an AED, how to obtain that, what to use it for, how to, make sure that the battery is up to date, all those things we need to be communicating this with our families. What to do in an emergency, as I said before, we need to be talking with schools and making sure they know what to do in an emergency. And then lastly, compliant with medications. This is very important. We need to start talking about this at an early age. And as some of the parents worry about their kids growing up and not taking the medications, if we get this early on, I think that, families are more likely to be compliant. There are many other resources for support. There are Facebook pages and blogs out there. There are local support groups. Many communities and many hospitals around the country will have support groups for certain types of genetic conditions. There can be peer support. I think SADS really does support this type of relationship and can help families get to each other if needed. We can have psychiatric care providers such as social work counselors, psychiatrists, or psychologists, and then also work on some stress reduction as needed. I think obviously the SADS Foundation International Conference is something we should be discussing with families. This is a great place for them to get the information that they need, as well as connect with other patients with similar types of diseases. The conference this year is in San Diego, coming up in September. So that's something to keep track of for your families as well, and encourage them to go to that conference. So again, keys to success include early intervention with the focus on the family. We must be collaborative. We must have effective communication. We need to provide psychosocial support to the family, as well as education to both the team and the family. So we need to make sure that everyone involved with the patient has the education that they need, and the family needs education as well. Early on, we should have a transition program or plan. So if it is a pediatric patient that needs to be referred to an adult cardiologist, we need to be talking about that early. And then also we need to perform multi-center research, which is going on throughout the electrophysiology community, and we are doing a great job at that. We need to continue to do so and work together to try to get more information from these families. So Mary, I'd like to pass it back to you and have you update on your family.
Yeah, our family is doing quite well. My daughter Esther has just recently gotten married. We have the picture at the bottom is my grandson Hunter. That's Hardies' little guy, and the new grandbaby Macy, and she does not have long QT. And my son Adam is in the picture with his wife Megan. They're doing well. We're avoiding the drugs. We're going through life's challenges quite well at this point. I would like to thank SADS for all the support that they have given us over the past few years. And you had mentioned that the educational material that I have used when they were in school was tremendous, helped us get AEDs in our local schools, in fact. And SADS provides support, has provided support for us at every need. It's easy to pick up the phone and call and get the information I need or want from them.
Okay, great. Well, thank you, Mary, for sharing your personal story. And thank you to Julianne and Bryn as well for taking the time out of your busy days to be here during this webinar and discuss your experiences with everyone. With that, I know we're right at time, so I guess we're going to have to stop there with questions for any questions. But if you have any questions, feel free to email SADS, and we can try to route those questions to the speakers. I guess we'll end here. Thank you, everyone.